the faculties. Thank you so much for being here. Sahiti, can we go live, dear?
Yes, ma'am, we are live now.
Okay. So on behalf of the OBGYN Pulse webinar series conducted by our own Dr. Vijaya ma'am, I invite all our chairpersons and the two eminent speakers for today. Welcome you all, madam. And can we start with the slide, please? Next slide. So introducing to you all our madam, Dr. Vijaya ma'am, who has been instrumental in many of the academic series and webinar series. She's been the convener in the past, in the April, about the Aksharam webinar series, and she has been instrumental in bringing out the OBGYN Pulse webinar series, which we are going on with. And she's had a vast experience of about 3 decades being a teaching faculty. She's now the candidate for chairperson for Foxy Medical Education Committee of 2025. Good luck to you, madam. And to give an idea, she has been a president of OGSI from 2024 to 25.
They are all reading, mother. No issues. We can go to the prayers.
Okay, ma'am. Very, very happy and blessed to have you as the academic mentor for many of us here. And
Can
we'll
I have
go.
Yeah, Madhu's slide. Yeah, Madhu is a gynecologist and a fertility physician, and she's working in Nova IVF Chennai as a clinical director. And she has got lots of awards and posters, and she's known for her debate and arguments and discussion. Name it, she'll be there in all of the Tamil Nadu conferences, be it OG or infertility. And her special interest is, Sagiti, you put that. No, I always forget. Special interest, just go up. Sagiti. Yeah, biological hair. Go to the Madhumita's slide, no? Madhupriya's CV. Yeah, she has special interest in the biological hair for poor ovarian and sperm reserve patients, and she's also interested in oncofertility. Welcome, Madhu, and she's been there with me. She's no way connected to Foxy, but yet because of me, she's there in all the webinars. Thank you,
Thank you. Thank you, ma'am. Thank you so much, ma'am. So we will start with the prayer as usual.
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि.
Thank you. Lighting of the lamp, please. Thank you so much. So going into the 7th webinar of this series, OBGYN Pulse webinar series, we have 2 good talks by 2 eminent speakers today. Let us get into the session number 1. So Vijaya ma'am, can I have you introduce the chairpersons and the speaker for the first session, please?
Dr. Chaya, she'll be joining now. She's the ex-CMO CGHS, a senior consultant, Hiralal Hospital, Ghaziabad, and present secretary GOGS, and she has a special interest in high-risk pregnancy. Chaya, we're waiting for you to join. Dr. Sonika, she's a senior consultant at Sanjeevani Hospital, Shahjahanpur, and she's an obstetrician and infertility specialist. She's the present secretary of Shahjahanpur and the past treasurer of 2020-22. And welcome, Sonika. Supriya ma'am, and she is an MBBS at Kolhapur and DGO at Core Institute Medical Sciences, served as a consultant in Gading Lodge and many lectures on female health educations in schools and colleges and Mahila Mandil, and she's a secretary at Gading Lodge OG Society and working as a full-time obstetrician and gynecologist at Bhavani Maternity and Surgical ICU. Welcome, Dr. Supriya ma'am.
Thank you, madam.
Dr. Ishita, she's director, Upkar Nursing Home. She's a treasurer of Upkar Society 21-22. At present, she's a secretary 24-25. And she'll be the vice president 25-26. She has special interest in recurrent pregnancy loss, high-risk pregnancy, and uterus conserving surgery. Welcome, Dr. Ishita. Yeah, now today is our first speaker of the day. Ma'am, Supriya ma'am, would you like to introduce Dr. Lakshmi?
Dr. Lakshmi Srikhande, she is a MBBS, MD, FRCUG, FICUG, and FIMS. She is a chairperson of Indian Congress of OBGYN from 22 to 23 and national correspondence editor of journal OBGYN Jogi since past 8 years, national corresponding secretary Association of Medical Women India, member of SAFOG Education Committee. She is a vice president-elect ISOPERP 2016-17, joint secretary of Indian Menopausal Society 2024, president of ISOPERP Vidarbha chapter 1921, chairperson IMS Education Committee 21-23, chairperson Fertility Enhancement Committee ISOPOP 23-24, president of Associate of Medical Women Nagpur 21-24, president Menopausal Society Nagpur 16-18, senior vice president Foxy 2012, and president of Nagpur OBGYN Society 2005-2006. Welcome, madam.
And thank you, Lakshmi, for accepting. I know you're very, very busy, but even then, I just asked you once, immediately accepted. I'm so happy. And over to you, Lakshmi.
Thank you. Thank you so much, Supriya, for your kind introduction. And thank you, Vijaya. And I wish you all the very best.
Thank you.
You are the deserving candidate, and I am with you.
Thank you so much.
Can you see my slides?
Yeah,
I
madam.
will make slideshow. Yeah, just a minute. So today I am deliberating on modern medical approach to fibroids. Just one slide about the overview that it is the most common benign tumor of uterus affecting 20 to 70% of the women of reproductive age group. Despite this high percentage of women affected by leiomyoma, it has been estimated that only 20 to 30% they will become symptomatic of their disease. And once they become symptomatic, symptoms will include heavy menstrual bleeding, pelvic pain, bulk symptoms, infertility, and recurrent pregnancy loss. I would like everyone to pay attention to the pathophysiology to understand the medical management of fibroids. The leiomyoma cells within a tumor, they do not rapidly proliferate, but rather the increase in tumor size is secondary to production of an excessive, stable, and aberrant extracellular matrix made of disorganized collagens and proteoglycans. And as a result, medical management should induce leiomyoma cells towards dissolution of this extracellular matrix as well as halting or inhibiting cellular proliferation. We all know that gonadal hormones, they induce and maintain leiomyoma growth via the production of an aberrant extracellular matrix. Much research has focused on the development of medical agents to circumvent this steroidal influence in an effort to reduce the burden of the disease. These medications, they include centrally acting gonadotropin releasing hormone analogs and peripherally acting agents which include aromatase inhibitors, antiprogestins, and selective progesterone receptor modulators. So what are the indications for medical management of fibroids? When woman wants to preserve her uterus, she's keen for pregnancy, she's not fit for surgery, or when surgery is not indicated. How does it act? Medical therapy, they act by controlling the symptoms, by reducing the fibroid volume, and by reducing the menstrual blood loss. The first agent which we all started using is combined oral contraceptive pills. Numerous studies have shown that COCs, they do not diminish uterine fibroid volume or uterine size. Moreover, they have minimal effects on other fibroid related symptoms, which makes their use for fibroid treatment very, very limited. However, the advantage of COCs are their accessibility, oral administration, and low cost. So still, many of our colleagues are prescribing COCs for fibroid management. Next agent which comes in line is levonorgestrel releasing intrauterine system. Its use in women who have myoma-induced HMB is limited. While the rate of intrauterine, this LNG-IUS expulsion is generally low, it is 0 to 3% in women with fibroids, but the expulsion rate increases to 20% if it is submucosal, submucosal fibroid. Therefore, its use is not recommended for submucosal fibroids. Now coming to the GnRH analogs in the fibroid medical management. GnRH is released from hypothalamus in a pulsatile manner, stimulating the anterior pituitary to secrete FSH and LH. And this FSH and LH, they drive ovarian estrogen and progesterone production, which in turn stimulates the fibroid growth. So suppressing GnRH leads to a hypoestrogenic state, thereby reducing the fibroid size and the symptoms. GnRH agonists are primarily used as either pre-op therapy or as transition therapy for those patients who are in their late perimenopause as they are waiting for their menopause to occur. Good quality data exist that GnRH agonists decrease uterine and fibroid volume, increases hemoglobin, and improves the perioperative outcome in those patients who are going hysterectomy and myomectomy. However, their side effects, they should be weighed against the benefits when you are using GnRH agonist for medical management of fibroids. Now comes the GnRH antagonist, which is a game changer in medical management of fibroids. There are various oral GnRH antagonists which are now available in the market. The first and foremost drug which comes to our mind is elagolix. Elagolix has two main advantages in comparison with our conventional GnRH agonist. First, it is an oral administered drug, while GnRH agonist, we all know that it is injectable. Secondly, elagolix has a short half-life which allows a more rapid elimination from the system, and elagolix does not block the pituitary axis completely. Elagolix in combination with estradiol and norethindrone acetate, it was approved by USA FDA in May 2020 for the treatment of fibroid-related HMB, and you can continue to use this drug for up to 24 months, that is for 2 years. The benefit of add-back therapy is that it mitigates many of the hypoestrogenic side effects of elagolix. However, the effect on fibroid volume reduction is also affected. Elagolix alone, that is without add-back therapy, has been demonstrated to improve fibroid-related HMB and may be an option for those patients who have a contraindication to add-back therapy. This is the recent study which has been published about the elagolix treatment, published in 2022. They used elagolix, they had two groups of patients, elagolix versus placebo and elagolix with versus the estradiol norethindrone acetate. You can see the conclusion of this study that elagolix appears to be effective in reducing HMB, caused by uterine fibroid, and combination with estradiol and norethindrone acetate was able to elevate the hyposteronic side effects in premenopausal women. How long you can use it? You can continue to use 150 milligram once daily for 24 months. If you are using 200 milligram BD, then you can continue to use it for 6 months of duration. However, you have to go on performing regular liver function tests when your patient is on this drug. You have to exclude pregnancy before starting elagolix, or you start elagolix within 7 days of her LMP. She has to take elagolix at the same time each day. She can take it with or without food. Start with the lowest effective dose, that is 150 milligram OD, taking into account the severity of symptoms and your treatment objectives. Limit the duration of use because of its adverse effect on bone mineral density. If she misses a dose of elagolix, she has to take the missed dose as soon as she remembers and resume the regular dosing schedule from then onwards. There are certain contraindications, that is pregnancy, known osteoporosis, severe hepatic impairment, and known hypersensitivity. If she is a known case of osteoporosis, of course, you are not going to start her on elagolix with or without ADVAC therapy. You have to counsel your patient that once she is started on elagolix, there will be change in her menstrual bleeding pattern, and this will reduce her ability to recognize the pregnancy. While regular liver function test should be done because of its adverse effect on hepatic transaminase. This is very, very important for all of us to know that it has interaction with hormonal contraceptives. So you have to advise your woman to use non-hormonal contraceptives during treatment with elagolix, and she has to continue this non-hormonal contraceptive for up to 28 days after discontinuing elagolix. As ovulation suppression with elagolix plus ADVAC therapy is variable, elagolix with ADVAC therapy should never be considered as a contraceptive. As I have highlighted in my previous slide, you have to put these patients on non-hormonal contraceptives till the duration of the therapy plus 28 days onwards once you have stopped elagolix. Lactation, we don't have any data. It is better to defer elagolix treatment when she is lactating. Do counsel her about adverse side effects in the form of bone loss, changes in menstrual bleeding pattern. Some women, they do get suicidal tendencies, hepatic transaminase elevations, hot flush, headache, nausea, insomnia, mood swings, and sometimes she can have amenorrhea as well. Drug interactions, everyone should know. Hormonal contraceptives, I have already highlighted. Second drug is cyclosporine, then rifampin and warfarin. Another oral antagonist which is available is relugolix in combination with estradiol and norethindrone acetate. It was approved by US FDA in May 2021 for the treatment of fibroid-related HMB for a duration of 24 months. A potential advantage of relugolix is its once daily dosing and the potential for greater reduction of pain and bulk symptoms as compared to elagolix. So this is the study which has shown the effectiveness of relugolix. The authors concluded that OD relugolix combination therapy resulted in significant reduction in menstrual bleeding as compared to placebo, and it preserved bone mineral density in women with uterine fibroids. We have a nice recommendations which came in 2022. That is relugolix estradiol norethindrone acetate is recommended within its marketing authorization as an option for treating moderate to severe symptoms of uterine fibroids in adults of reproductive age. The third oral GnRH antagonist which is available in the market is linjagolix. It can be given as a 100 milligram or 200 milligram once daily tablet, and you can give it with or without ADVAC therapy. This is the study which was published in 2022. And here again, the authors concluded that linjagolix in the dose of 100 mg or 200 mg with or without add-back therapy significantly reduced HMB caused by uterine fibroids. So in which cases you can give oral GnRH antagonist, preoperative patients who are waiting for myomectomy, for non-surgical managements of HMB caused by fibroids, when she wants to preserve her fertility, and those women who are not willing to go for surgical interventions. As GnRH antagonist has many benefits over traditional treatments in the form of rapid symptom relief. There is no estrogen surge or flare-up phase. It can be given orally, low risk of severe menopausal symptoms, and it can be used as a long-term therapy that is up to 24 months with appropriate monitoring. However, you have to consider the bone mineral density loss, and it is not suitable for pregnant and lactating women. The second drug which is available to us is selective progesterone receptor modulators. How they act? Selective progesterone receptor modulators on fibroids, they cause decrease in fibroid size and volume. In HPO axis, they inhibit ovulation, and on endometrium, they induces amenorrhea. Ulipristal acetate, we all are well versed with its history, so I am not going into the details of the history, how that drug came into practice, and we are advising it for the medical management of fibroids. This was approved by our own DCGI on March 14, 2018 for pre-operative treatment of moderate to severe symptoms of uterine fibroids in adults of reproductive age and intermittent treatment of moderate to severe symptoms of uterine fibroids in adult women of reproductive age. But in November 2020, following reports of serious liver injury in the Europe, this drug was withdrawn from the market. Again, December 2022, the director of FDA Goa, they issued that yes, it can be dispensed, it can be used for medical management of fibroids, but you have to continuously monitor the liver function test. This I have taken from the review article which was recently published in 2024, that in which cases you can use ulipristal acetate. So you can safely use this drug for the preoperative treatment of women with fibroids of 3 cm or more. Intermittent treatment in women who are not eligible for surgery, for example, where the risk of surgery are more. UPA may used in the dose of 5 mg for up to 4 courses in women with HMB and fibroid of 3 cm or more in diameter. The clinical efficacy and safety, both with regard to preoperative administration as also with intermittent administration for symptomatic uterine fibroids, have been shown in several clinical studies. Besides, UPA has also been reported to improve the quality of life of patients with fibroids. So I'm just quoting one study to increase your confidence when it comes to prescribing UPA for the medical management of fibroids. Here, the authors, they gave 2 courses of 5 mg of UPA orally for 12 weeks starting from the day 5 of their menstrual cycle, with a 2 menstrual cycle break in between. And they concluded that 2 interrupted repeat course of 5 mg UPA is well tolerated, efficient, and safe in symptomatic fibroid among Indian women. So the potential advantages of this drug include retaining fertility, providing symptomatic relief, preventing the need for surgery, allowing for fertility treatment, and preventing recurrence of fibroids after surgery. The third drug which is available is aromatase inhibitor. Several in vitro studies have revealed that uterine leiomyoma cells, they harbor intrinsic aromatase activity, thereby providing a direct source of steroid hormone to drive further growth through the development of an aberrant extracellular matrix. These findings stimulated interest in the utilization of aromatase inhibitors as pharmacological agent in the treatment of fibroids. There are several publications which have shown reduction in leiomyoma volume and symptoms with the use of these agents, but we don't have well-designed trials, and in the absence of these well-designed trials, it is not approved by FDA for the treatment of uterine leiomyoma. The next drug which is available is antiprogestins. Mifepristone, which was also known as RU486, is the most extensively studied progesterone receptor antagonist in the treatment of fibroids. This compound is a competitive antagonist and it has higher affinity for the ligand binding domain of the progesterone receptors than does the progesterone. Several studies have shown mifepristone is capable of improving the symptoms and reducing the volume of fibroids. There are various studies which have shown that mifepristone at a dose of 5 to 50 milligram for 3 to 6 months, they can decrease the HMB and they can decrease the fibroid volume. Another very interesting, fascinating molecule which is in the picture is statins. Recent research has demonstrated that uterine fibroids may be treated using anti-hyperlipidemic medication, that is statins, as statins cause apoptosis and it suppresses the growth of fibroid cells via calcium-dependent pathways. Additionally, low doses of statins can prevent extracellular matrix protein production in myomas. But as of now, we are not using these drugs in the clinical practice for want of the trials. So the key takeaways from my talk, friends, is symptomatic uterine fibroids, they require surgical or medical therapy according to the FIGO classification, severity of symptoms, patient's age, infertility, and her desire to preserve fertility. Decision about uterine fibroma treatment must balance the risk and benefits and should be individually based on patient's medical conditions, symptoms, and her wishes should be taken into consideration. New drugs like oral GnRH antagonist and ulipristal acetate are now DGCA and FDA approved, and they are the game changer in the medical management of fibroids. Thank you, friends. Thank you for your patient hearing, and please vote and support me for the post of Foxy representative to AOFOG. Voting will be from 1st to 10th of August, and this will be an online voting. Your questions, comments, and concerns are most welcome. Thank you once again, and thank you, Vijaya, for this opportunity to share my thoughts on newer management of fibroid treatment.
Excellent, excellent. And it is crisp and what is needed. You have told all the points and all the new drugs, especially the elagolix is a game changer now. I would like to ask the chairpersons to throw your Seema. Dr. Seema. Unmute Seema.
So, ma'am, it was excellent talk as always. I've always heard your, like you were here in Lucknow, I heard your talk on hysterectomy. So, excellent talk, very enlightening, and especially the elagolix part. And we have also started prescribing elagolix for our patients with some fibroids. But the only problem is the cost, which like patients find it a little hard to afford this. And the other drugs, yes, ulipristal acetate we have been using. So all in all, a very comprehensive talk. Congratulations, ma'am, once again for your wonderful talk.
Thank you. Thank you. But elagolix, if you start use 150 milligram OD, I think it can fit into the budget of the patient. And 150 dose does not need add-back therapy if you are using it for only 6 months. But beyond 6 months, it is better to add add-back therapy.
Dr. Supriya, your comments.
Yeah, madam, just I want to ask that add-back therapy all the time we have to go calcium carbonate and other things along with that drug, elagolix?
I did not get it. Calcium supplementation you are
Yeah,
asking?
yeah.
Yeah, because you have to be very, very alert as far as bone mineral density loss. But now so many papers have come that if you are using Elagolix 150 milligram for 6 months, it does not affect, or rather it has a very, very minimal effect on the bone mineral density. So you might not give calcium supplementation if you are using Elagolix in a that is minimal possible dose for minimum possible duration of time. But if you are using Elagolix for longer duration, that is 150 milligram is approved for 2 years. So if you are using it as a prolonged therapy, then yes, it is better to consider add-back therapy also, and it is better to give calcium supplementation as well. But if you are giving add-back therapy, it will not have any adverse effect on the bone mineral density. So you might not give calcium supplementation. The role of calcium supplementation comes when you are using Elagolix without the add-back therapy.
Okay.
And as such, our all perimenopausal women are calcium deficient. If you are doing their BMD testing, their T score is always in the osteopenic range. So it makes sense to give them calcium supplementation when it comes to the Indian woman, because they are always deficient, they are always osteopenic.
Yeah. Thank
Dr.
you.
Sonika, would you like to add some comment? Ujjwala was also there. Unmute.
Yeah, hi, hello, good evening.
Yeah, not seen. Switch on your video.
Yeah, I'm traveling, I'm in car, so
Okay.
my video is off.
Okay, no issues, no issues. Yeah, please.
Yeah. The half the time I was on highway, so I could not hear all the talk what was going on. Very sorry for that. I contacted Dr. Vijaya and then I could join that.
Ujjwala. Anyway, it will be uploaded in the YouTube. Don't worry, Ujjwala. All excellent talks.
Yes, yes.
It's up.
Sure, sure.
Yeah,
Yeah,
thank
yeah.
you so much for joining in spite of the busy schedule. And Sonika was also there. I don't know where she is. Maybe for the next talk. Only one thing I want to ask Lakshmi. When should we do rescan? Whether the fibroid has disappeared, how should we ensure?
Better to rescan them after 3 months.
After stopping the drug.
After stopping the drug. No, when she is on drug, you have to do liver function test, and even if she is on the drug, you want to document whether it is really helping her in decreasing the fibroid volume and size. So it is better to scan her after 3 months to
Oh.
see that it is really working. Of course, the another way of assessment is that she will have symptomatic relief, that is in the pain, in her heavy menstrual bleeding. So that way also you can assess her.
Okay. Got it.
Lakshmi ma'am, I have one question. Like, what is the maximum duration we can give Elagolix? Because you said it should be given for limited duration. It affects the
Yes.
liver function test as well. So,
But Elagolix is approved by FDA. 150 milligram OD is approved for 24 months. You cannot give it beyond 24 months. If you are giving 200 milligram BD, then this dose is approved for only 6 months. So we should not go beyond 6 months for this dose, that is 200 milligram BD.
so ma'am, the higher dose is for what? Like, it's for a bigger size fibroid, or like, how do we decide the dose?
If your patient wants quick symptomatic relief, if she's having HMB, big fibroid, you can start. But the general rule is that start with the minimum possible dose, that is start with 150 milligram OD dose. See whether she is improving, her symptoms are improving, whether there is a reduction in fibroid volume, and if she is improving symptomatically, continue with the same dose. And you can give it for 24 months, but don't go beyond 24 months. And when she is on the treatment, 150 milligram OD, you can do liver function test every 3 months. I mean, you need not do it daily or monthly.
Thank you, ma'am.
Dr. Sonika, unmute.
Yes, ma'am. Thank you so much, Dr. Lakshmi, ma'am, for such an enriching talk, and definitely have gained good knowledge, especially regarding Elagolix. I haven't used it yet, but yes, after this much of information, I'll definitely try it on patients.
So
And all the best, ma'am.
confidently use 150 milligram OD without add-back therapy, without any without any monitoring. You start the dose. But of course, do baseline liver function test and then start, just
Yeah.
for your own safety. And for 3 months, though, you can continue it, I mean, without any monitoring.
Okay, ma'am. Ma'am, any recommendation for the size of the fibroid? Where do we use elagolix or any
No,
other?
as of now, I have not come across any studies which has mentioned the size. You should use elagolix for this size only. It is the clinician's discretion. See, nowadays we talk in terms of shared decision making. Every decision has to be a shared decision making. So here also it is the shared decision making between the treating clinician and the patient, depending on her symptoms, the size and volume of the fibroid, because you have to give them all the options. You have to tell them the benefits and side effects of all the options. And by shared decision making, I mean that it is the patient who chooses one approach after you have counseled them. So it is the cafeteria approach. You can't tell them, ki, okay, I will be giving only elagolix. She will go to Google, she will read so many drugs, and then she will come and ask me, you have not told me about this other drug. So what we do tell them ki these are the therapies available, these are the benefits, these are the side effects, and let them choose.
Okay,
Gone are the days when we used to take decisions for our patients.
Right,
One
ma'am.
question.
Hello.
Suppose if you are giving for a small submucous fibroid who's wanting to conceive, how many months she has to wait after stopping elagolix to start her pregnancy?
1 month.
One
I
month.
told you, when your patient is in elagolix, you have to give non-hormonal contraceptives till the duration and after 28 days. So let her have 1 or 2 menstrual bleeds, and then you can go ahead and start your fertility treatment.
You mean condoms or you mean this again?
Non-hormonal, yes. But condoms, they have to use it consistently and correctly, because condoms have 30% failure rate. And when your patient is in elagolix, there is a change in her menstrual bleeding pattern. So she will not be able to recognize whether she is pregnant or not. So if she is having any abnormal change in her menstrual bleeding pattern, do counsel her, tell her that she should do urine pregnancy test at home or she should come to you.
So what is the other option she has? Saheli, yeah?
Pardon?
Saheli, not hormonal contraception.
No, non-hormonal contraceptions, when it comes, I mean, if it is not submucosal fibroid, you can even go ahead and use Copati. That is IUCD.
Okay.
But for submucosal, you cannot go ahead and use IUCD.
So we can use armiloxifene, I think. I don't know whether Saheli.
No, don't combine it, because we don't know the drug interaction.
So we don't have much option then.
Don't give her any oral, because I have not come across any studies where they have made a non-hormonal contraception by giving Centroman or Saheli to these patients who are on elagolix. So go with time-tested, I mean, the safest way is condoms or IUCD if it is not submucosal fibroid.
Okay, done.
And condoms, they use it. Once you counsel them properly and you tell them to be liberal with urine pregnancy test when they notice any change in their bleeding pattern, you are safe and she is safe.
Yeah.
And suppose madam she get conceived during her elagolix therapy, then
There is nothing is in the literature. Again, you have to counsel her. I have not come across any studies where they have shown that it is an indication for medical termination of pregnancy.
But we have to advise her termination of pregnancy then.
Why? Just it's a shared decision making. Counsel her. Tell them upfront that till date. See, nowadays, I don't know whether Google has made our life easy or difficult, but sometimes it has really made our life very, very easy, because patients, they read, they know our limitations. So you can tell them upfront that this is a new drug. As of now, we don't have long-term safety data. As of now, we don't have any studies where there is a chance pregnancy on elagolix and the outcome of that pregnancy. Tell them upfront. So we really don't know. So it is up to you whether you want to continue or you want to terminate the pregnancy. Tell them, counsel them.
Yeah.
And it is true because we really don't have long-term safety data as of now, because we all have started using it elagolix, I mean, just 3 months or 6 months back. And now so many companies have come with elagolix that I'm sure more and more gynecologists, they will be started, they will use it. And now after 2 years or 3 years, we will be having a safety data or our experience of use of elagolix of 1 year or 2 year, provided we all come forward and publish and share our data to the journals. But as of now, we don't have. And I tell my patients that this is a new drug approved by FDA, but we don't have any long-term safety data.
Relugolix is available in India.
Yeah, Amazon, online. Nowadays, so everything is available on online.
3 companies are available.
Yeah, and so many companies. Every company is promoting elagolix, but I have seen it is available online. And I'm really surprised why companies are not coming with relugolix, because it's shown to be more safe as compared to elagolix.
Okay.
When it comes to its effect on bone mineral density.
Okay, Lakshmi, I think if there is anything, we'll be putting in the chat box. And thank you so much and all the very best for you. And we'll definitely support you. Thank you so much.
Thank you. Thank you so much.
Madhu,
Thank you so much, ma'am. Thank you so much for that wonderful session 1. With the same enthusiasm, we are expecting the second sessions to start now. Vijaya ma'am, would you like to introduce the chairpersons and the speaker for the second session, please, ma'am?
Yeah. Dr. Seema CV was there, no, earlier. She's a professor, Department of Lucknow. And Seema CV was there. She has sent
I'll introduce myself. So I'm currently, I'm working as professor in Department OBGYN KGMU Lucknow, and I'm currently secretary of Lucknow Obstetrics and Gynecological Society, ma'am.
Yes, ma'am. Thank you. Dr. Ujjwala is a director of Yash Nursing Home, and she's the president of IMA Bhiwandi for the last 5 years, and she's the recipient of MediQueen Excellent Award, President Appreciation Award from Maharashtra IMA, and she has won many awards, Navadurga and Mahapur Shashak, and she has rendered services to the people wholesomely, and very important school programs, de-addiction programs with the IMA and free breast and cervical cancer detection program. Welcome, Ujjwala. Thane Obstetric Gynec Society Secretary, and Dr. Arushi, and she's MBBS from Gulbarga and MS from Odisha, and she's a certified course she has done in laparoscopy, colposcopy, and cosmetic gynecology, and also in IUI, and basic obstetric ultrasound and gynec ultrasound. She's a member of FOXY, and she's a secretary of Ichal Karanji OBGYN Society. She has interest in cosmetic gynecology, laparoscopy, and infertility. Welcome, Arushi. Bhagishi ma'am, and she's the honorary secretary of Aurangabad Obstetric Gynec Society, and she's the honorary treasurer of AOGS 2019 to 24, and she has presented a paper state and national conferences, contributed a chapter on internal iliac artery ligation in the Das Gupta's recent advances, and he has given health awareness talk in various programs. Welcome, Bhagishi. Yeah, now the speaker is Seema ma'am. Please introduce Dr. Shruti.
So at the outset, I would like to thank Vijaya ma'am for making me part of this very interesting webinar. And I wish her all the success for her upcoming elections. And all the best, ma'am. And now coming to our speaker for the next talk, and I'm happy to introduce Dr. Shruti Shivadas. She is consultant gynec oncologist working at Site Care Hospital, Yelanka, Bangalore. And she is MCH Gynec Oncology. So I think she's the right person to talk on this important topic of endometrial carcinoma. So over to you, Dr. Shruti.
Thank you, madam. Thank you for that lovely introduction. Let me just share this thing.
Any difficulty in sharing? Let us know, ma'am. You can send across the PPT. Yeah.
Okay, I'm not sure. Archana बोल के देता ते जो Archana बोलेंगे. Is it visible by any chance?
No, ma'am.
Not yet.
Not yet, ma'am. You're a co-host now.
Okay.
At first, please open the PPT, ma'am, and then come to Zoom. Click on share option.
I'll just leave the webinar and back in.
Okay.
Hello, is it visible, madam?
Ma'am, we are
Yes,
able to see your Zoom screen.
Yes.
We're able to see the Zoom screen.
Yeah. Yeah.
Yes, now, ma'am. You can get the screen
Yes.
wider.
Perfect,
Yes,
ma'am.
we're able to see.
Okay. Thank
Yeah.
you.
So at the offset, thank you very much for the society for giving me this wonderful opportunity, and Vijaya, madam. Thank you, madam. So the talk is on updates of endometrial cancer. But then madam had specified to me that the audience is going to be mainly residents of MS OB/GYN. So then I have actually tailored the talk in that way so that it is entirely covering, the basic histology and classification, staging, molecular classification, pre-invasive and invasive lesions, including sarcoma. So I've also just put 1 or 2 slides on sarcomas as well. So yes. So why should we know about endometrial cancer? So currently, definitely endometrial cancer is on the rise. So these are the GloboCan statistics of 2022. So we can say an increasing in the rank of the, uterine cancers in general, when you're combining male as well as female cancers. And then when you're going to look at the incidence in female cancers alone, it stands at 6th position. So this has come up from a lower position up now. And if you're going to look at women-specific cancers, uterine cancer now holds a 3rd position. And of course, we know the reasons: increasing income, increasing obesity, poor food habits, change in the reproductive patterns, people having no children, less children, or delayed childbirth, and of course, an aging population. Okay. So just the contents are going to be in the different types of the malignancies of the uterus. Risk factors, pre-invasive lesions, the pathological classification of uterine cancer, surgical pathological staging, that is the figure 2023, molecular staging of uterine cancer, investigations in atypia and cancer, and management of both atypia and cancer, and just a slide or two on uterine sarcomas. So basically, what are the malignant neoplasms of the uterus? So this, as I've said, I've put the slides mainly aiming at a PG or a resident group. So if I want to look at what the basic difference between carcinoma and sarcoma, so these are the two broad malignant tumors of the uterus. So carcinoma is what arises from the endometrium or the inner lining of the uterus. And sarcoma, if I'm going to broadly say, it is what arises from the myometrium of the uterus. So we have the endometrium, the myometrium, and the serosa. So the endometrium is what gives rise to carcinoma, and the myometrium is what gives rise to sarcoma. However, sarcoma is not that simple. So sarcoma basically means a tumor of mesenchymal origin. So the mesenchyme can be in the endometrium. The mesenchyme can also be in the myometrium. So I have, in order to further simplify that, I have put this, histological section, histopathological section through the uterus. If I'm going to take a small bit of the uterine wall, so this is how it's going to look under the microscope. So this is the endometrium, consisting of the endometrial lining, the endometrial glands, and the stroma. And then we have the myometrium. The perimetrium doesn't hold much value for us. So tumors which arise from the endometrial lining and the endometrial glands basically are carcinomas. And the current concept is that carcinosarcoma, or what used to be previously called malignant mixed Mullerian tumor, are also a de-differentiation of carcinoma, which means they all arise from either the endometrial lining or the endometrial glands. Okay, so that is what carcinomas are. Now, if you're going to look at sarcomas, the sarcoma can arise from either the myometrium, the simplest thing to remember, which becomes a leiomyosarcoma. That is the simplest one. One is a sarcoma which arises from the myometrium, or the muscle layer of the uterus, which becomes leiomyosarcoma. Then there is another set of sarcomas which also arise from the mesenchymal layer, mesenchymal component of the endometrial layer. Okay, so let me be very clear. From the mesenchymal component of the endometrial layer, that is the stroma which surrounds these glands. So glands are the epithelial layer and stroma becomes the mesenchymal layer. So if you have tumors arising from the stroma, that is what becomes the endometrial stromal sarcomas as well as the adenosarcomas. So adenosarcomas are a combination of glandular as well as stromal malignancies. Of course, the adeno part, the glandular parts are generally not malignant. They are benign epithelial components along with the malignant stroma. Okay, so I hope that is very clear there. So let me tell up front that we have some current fluctuations at home. So sometimes the current light might go off, but the net will be on. So just coming to the risk factors of endometrial cancer, I think almost everybody knows it. It's very simple. Most carcinomas of the endometrium are related to estrogen excess, which can be from a long menstrual phase, which means early menarche and late menopause. It can be from not having pregnancies to break your estrogen exposure, excessive obesity, which itself is a cause of hyperestrogenism, treatment with tamoxifen and estrogen replacement therapies. And the other causes, age. Age is the #1 causative factor for all cancers. As you age, you're increasing the risk of developing mutations and developing cancers. And then, of course, familial cancers and prior radiation therapy. So prior radiation therapy for pelvic cancers generally increases the risk specifically of the type 2 cancers, carcinosarcoma and undifferentiated carcinomas. So now coming to the next part, which is the pathological classification and otherwise of endometrial carcinomas. So I'm sure that a lot of people are aware of this classification, wherein carcinomas are divided into type 1 and type 2. So just recapping that I'm talking currently only about carcinomas, which are malignant transformations or including pre-invasive lesions of the endometrial glands and the lining, okay, not the stroma. So it's broadly divided into type 1 and type 2. Type 1 carcinomas are in the background of estrogen, hyperestrogenism. Type 2 are the ones that come in the background of atrophic endometrium, which means they are more common in women in the older age group, that is late postmenopausal or senile women, whereas hyperestrogenism is generally seen when you have the anovulatory issue of perimenopause. And the histopathological type is generally an endometrioid carcinoma in a type 1. It can be uterine serous, clear cell carcinosarcoma, squamous cell carcinoma, mucinous carcinoma, or any of those rarer varieties in a type 2 carcinoma. And of course, we all know that the clinical course is much more aggressive for type 2 carcinomas. They have a high mutational burden, they are higher grade tumors, and generally have a poorer prognosis. Okay. So, and this is the WHO 2020 or the latest classification of endometrial cancers. So you have, again, the different histological types, as I've already mentioned, of which the endometrioid carcinomas are further subdivided, also have a molecular classification, which has been incorporated into the WHO pathological classification. I will be dealing with that a little bit later. So here, the other thing that I want you all to take home is that though we say endometrioid adenocarcinoma is type 1, not all endometrioid carcinomas are anymore considered as type 1, though initially we were. So the current concept is to include grade 3 or high-grade endometrioid carcinomas, as well as P53 mutated endometrioid carcinomas in type 2. Okay, I hope that is very clear. So even if your type is endometrioid, doesn't mean that it's always type 1. So if it's a P53 mutated endometrioid or a grade 3 endometrioid, that is considered as a type 2. Now that is about the classification and the staging. So now coming back to pre-invasive. So I'm afraid that I'm going to be moving in and out of various sections. So I've just put it in a particular order that I felt might be easier for me to present. So this is the hyperplasias and atypias, which are the pre-invasive lesions. So the latest classification is the 2020 WHO classification, which just classified it as hyperplasia without atypia and hyperplasia with atypia. So earlier it used to be simple without, complex without, simple with, and complex with. So all that is now divided. It doesn't matter how the glandular morphology is. So it is only the presence of atypia, which predisposes or increases the risk of cancer. So that is the basic concept. So now it's either with atypia or without atypia. The hyperplasia basically just refers to an increase in the glandular numbers and crowding. The atypia refers to the glandular, the nuclear atypia, as well as the absence of stroma. Okay, so that is how they differentiate this morphologically. There's another set of classification called the EIN classification, where atypical hyperplasias are also referred to as endometrial intraepithelial neoplasias. And these basically are the precursor lesions for type 1 or endometrioid cancers. Okay, so these are the basic precursor lesions for type 1 endometrioid cancers and even grade 3 endometrioid cancers. Okay. So basically, it is the atypical hyperplasia, which is generally considered as a pre-invasive lesion for the type 1 because of a high risk of progression of 20 to 40% to carcinoma and a concomitant already existing carcinoma risk of around 40%, which has been missed in your preoperative biopsy. Hyperplasia without atypia has a very small risk ranging between 1 to 5%. So this is not generally considered as a pre-invasive lesion. Then the other thing that probably PG's residents should know is this term that has been coming into vogue recently, which is the serous endometrial, sorry for the typo, serous endometrial intraepithelial carcinoma, which a lot of people consider as a precursor lesion for type 2 uterine serous carcinoma, or the UPSC as it's generally called. So it is not so straightforward. So all the type 2 carcinomas can occur in the background of atrophic endometrium, and you can actually miss it if you're going by the cutoff of endometrial thickening alone. So serous endometrial intraepithelial carcinoma is not just a precursor lesion. That lesion in itself is potentially metastatic because this is similar to stick in CA ovary. So this can be just shed into the peritoneum via the tube and can cause metastasis, even though the lesion in itself is not invading the myometrium. Okay, so because of that, the ESGO-ESTRO actually refers to this as non-invasive carcinoma of the uterus with an abnormal P53, and it should be treated with surgical staging if it is at all picked up. And whether lymph node staging actually matters is doubtful because, as you can imagine, this is being about shedding into the peritoneum, so lymph node involvement might not be so high. But whenever possible, we would definitely prefer that it be staged completely with a lymph node staging, and there is no consensus on adjuvant treatment. So this is a very poorly studied or poorly described pathology. So the next thing, of course, I'm going to is the staging or the surgical pathological staging of endometrial cancer. I'm not sure how many of you among the audience is familiar with it, but the FIGO has come up with the latest, which is 2023, which is a bit more complex than the previous simple staging. So as you can see, stage 1 is split into so many stages. So which one initially had only 1A and 1B was the latest stage. So now there's 1C again popping back in. 1A is again split into 1A1, 1A2, and 1A3. So 2 used to be a single stage, so now it is 2A, B, and C. And all the third stages have 2 subdivisions. Previously, only 3C had a subdivision, and there is an additional 4C. Okay, so these are the different changes that have come, of which, so the catch here is that this staging has also incorporated various other pathological and molecular factors. So one is the addition of LVSI to decide between 1B and 2B. So this is based on the presence of LVSI or not. Similarly, tumor histology. So if it's a type 2 tumor, it becomes either 1C or 2C in an early stage, depending upon whether myometrium is involved or not. Similarly, ovarian metastasis and synchronous ovarian tumors have been specified. So there are particular criteria wherein if it fits into a particular criteria, it is a 1A3, which is a synchronous tumor of the uterus and the ovary. And if it doesn't fit those criteria, it becomes a 3A1, which is a metastatic tumor from the uterus to the ovary. So the basic thing here is whenever you have 2 tumors in the uterus and the ovary of the same pathology, the uterus is generally considered as the primary and the ovary is generally considered as the metastatic site, because ovary is a very good soil for a seed. So that is the concept. Okay, so that is the metastatic site. And how do you differentiate whether it's a synchronous or a metastatic tumor? There are distinct criteria which has been set by FIGO. Then, of course, is the addition of peritoneal implants in the staging. So pelvic peritoneal implants have a slightly better prognosis than the abdominal peritoneal implants. And so one is in 3B2 and the other one is in 4B. And distant metastasis has been moved down to 4C. And of course, molecular staging has also been incorporated into the Fibro staging. I will be dealing with that a little later on.
Just go back, no, that slide, how to differentiate between 1A3 and 3A1. Little bit,
Yes, ma'am.
little bit slower.
So there is a distinct criteria. Yes. So one is that it is an endometrioid type 1 tumor, low grade, grade 1 or grade 2, and it is a unilateral ovarian involvement. The myometrial invasion is less than half, not more than half, and there is no extrapelvic disease, and the tubes are free. So if all these criteria are met, it is considered as a synchronous, like together occurring separate primaries, which is staged as 1A3. And that does not need any particular treatment. But if any of these criteria are not met, so if all of these criteria are met, it becomes 1A3. If any of these are not met, then it is considered as 3A1. So suppose you have a type 2 tumor in the endometrium, then it naturally becomes metastatic tumor. Similarly, if you have more than half myometrial invasion, it becomes a metastatic tumor. If you have bilateral ovarian involvement, it becomes a metastatic tumor. If the tubes show tumor, it becomes a metastatic tumor. So these are the criteria that we use.
Thank you.
Yes, ma'am. So coming to the molecular subtyping of endometrial cancers, again, this is something a recent advance. So previously, endometrial cancers, we would just base it on type 1 and type 2. So that was it. It was so much simpler then. But now we know that even within the type 1, which we generally consider as a good prognosis thing, there is a subdivision which is not so good prognosis. So there is a very good prognosis, there is an intermediate prognosis, and then there is a poor prognosis. So this is where we use the molecular typing. So this is based on either IHCs, we can use immunohistochemistries in the preoperative endometrial biopsy or in the final histopathology specimen. For some of these, we also have, for testing for pole mutation status, we have to use Sanger sequencing. So we have to do a DNA study. So all the others can be done on IHC. So to find a P53 abnormal, to stage it as a subtype it as P50 abnormal, a P53 IHC testing is sufficient. To subtype it is a mismatch repair gene problem or a high mutational burden one, we can just do the IHC staining for these proteins or a MSI analysis on the tumor. For if none of these fit, it becomes an NSMP, which is no specific mutational pattern. For pole testing, we need to go for a DNA analysis. Okay, so these are the only methods that are available for pole. So of this, the most common one that we see is generally in a type 1 is an NSMP, which has an intermediate prognosis. Similarly, a mismatch repair gene also has an intermediate prognosis. The least commonly one seen is the pole mutation, and that has an excellent prognosis even in very advanced stages. Okay, so that is the thing there. So sometimes you might have a stage 3 tumor, but if you have a pole mutation analysis which is positive, that might be a very good tumor which might not need any adjuvant therapy, which might not need an extensive lymph node dissection, which might not need an omental biopsy. Okay, but at the same time, the tumor might be a very early no myometrial invasion on the MRI before we are operating, but the endometrial biopsy IHC might be P53 mutated. But that is a bad tumor. So that we would have to consider as a type 2, and we have to do an extensive lymph node dissection, and the patient is going to receive adjuvant therapies later on. So that is why we have incorporated this molecular subtyping also into the FIGO staging now. Okay, so this is going to be using IHCs and DNA testing. Okay, NGS. So gene sequencing and IHC is what is used to subtype these endometrial cancers. And what do we do it on? We can either do it on the preoperative endometrial biopsy, or we can do it on the final histopathology specimen. But it is ideally to be done on the preoperative biopsy. Why? Because it is an excellent concordance with the final histopathology. And only if you do it in the preoperative biopsy does it help in your treatment plan. So if you're not going to do it in the end, it might only help in your adjuvant planning. But if you want it to actually help in your surgical planning, you need to do it, of course, in your preoperative biopsy. Okay, so this is the recommendation. And now this has been incorporated into the 2023 FIGO staging, wherein what they have done is only the early stages, any stage, if it is pole mutated, it becomes the earliest stage, 1A. And any stage which is P53 abnormal becomes the last stage, which is 2C. I hope that is clear. So 3 and 4, they have not really used it for molecular staging. So currently, stage 3 and stage 4 are being treated as if they're advanced and they're given adjuvant. But in stage 1 to 2, that is the early stage of endometrial cancers, we are using the preoperative endometrial biopsy also to either upstage it or downstage it. Okay. So pore mutated gets downstage to very early stages, irrespective of which actual stage pathologically they are in. Similarly, a P53 abnormal becomes upstaged to 2C, even if they might actually be a 1C. So
Shruti, can I interrupt?
yes, madam.
Yeah, suppose the less than 50% of the myometrium, all are seen only in the post-operative specimen, no? If just the endometrial sampling, we don't know much about it. And also the ovary involvement.
Yes, ma'am. So when we are staging endometrium preoperatively, so we stage endometrium, all malignancies generally, we will have a presumptive stage preoperatively. And we have a final stage, which is post-operative, which is the ultimate stage. So the presumptive preoperative stage is based on our biopsy as well as our imaging. Imaging, yes.
Okay.
So this is like, suppose I do an endometrial biopsy. It becomes a grade 1. It comes as a grade 1, low grade endometrioid tumor. Okay, so it's a type 1. And I do an MRI. The MRI shows no myometrial invasion or say less than half. So now for me, it is a very early stage tumor. But if I'm going to do IHC on that tumor and the tumor comes as P53, so now the tumor is a 2C. And this needs an extensive lymph node dissection. But otherwise, if it were a stage 1, grade 1 endometrioid, no myometrial invasion, I don't need a lymph node dissection at all.
Yeah, got it.
That is how that preoperative molecular staging has been incorporated preoperatively itself now. So earlier we were using molecular staging when it came out initially, we were using it only for our adjuvant treatment. But now this has been incorporated and we are using it also in our preoperative treatment planning.
Thank you.
Yes, ma'am. So that is about, so I have completed so far the different classification and the pathological classification, the surgical pathological staging and the molecular staging. And we have also discussed atypia classification. So now I'm moving on to when do we investigate AUBs, who and when, okay, as well as how. So generally, all of these, we expect them to present with some sort of abnormal uterine bleeding. Of course, it has to be remembered, these type 2 cancers can present with just watery discharge per vagina, okay, or foul-smelling discharge per vaginum. They have to be looked at with always a suspicious eye, especially when you see it in an old, thin lady. Several years after postmenopause, you have to always think of the possibility of there being a type 2 cancer or even a fallopian tube carcinoma. So these are the two things we'll always think when we see a thin old lady with no other risk factors presenting several years after menopause with a discharge PV. This is something that you think about. But otherwise, in general, malignancy is present with bleeding, right? So who do we investigate? Any woman by about the age of 40 years definitely needs an investigation because the risk of malignancy increases suddenly from 1 to 10%. So there's a 10 times rise. Younger women less than 40 with other risk factors, persistent anovulatory bleeds, long-standing polycystic ovaries, strong family history, obese, infertile, I would prefer to do an endometrial biopsy for them. And if I'm going to go by the endometrial thickness cutoffs, generally the cutoffs would be endometrial thickness of more than 5 millimeters in postmenopause, HRT bleeds which are unscheduled, bleeding while on tamoxifen, endometrium more than 12 millimeters irrespective of the cycle in premenopausal, and endometrial thickness more than 8 millimeter on tamoxifen even if the patient is asymptomatic. So these are all query. These are not really established guidelines. These are some of the things we use to guide our practice. They are not definitive guidelines. But generally, when a postmenopausal woman comes to me with a bleed, we always prefer to do an endometrial biopsy. We don't really look at the cutoffs. But you can, if the patient is very reluctant to go for an endometrial biopsy, it is fair. You get a transvaginal scan or an ultrasound. The endometrial thickness is less than 5 millimeter. The bleeds were not heavy. The bleeds were only spotting. I would think of, okay, this could be an atrophic endometrium. You could either wait it out or you can give her low-dose estrogen vaginally. But otherwise, in general, we generally would prefer to do an endometrial biopsy for all women who come with postmenopausal bleeding or women who bleed on tamoxifen. If the person is on tamoxifen for breast cancer, generally asymptomatic bleeds do not need endometrial biopsy sampling. But some people use this cutoff of 8 millimeters. I also do sometimes use the cutoff of 8 millimeters. And if I feel it is a polyp, so I always look for a transvaginal scan, see if it is a polyp. If it's in favor of a polyp, I directly take them for a hysteroscopy. If our radiologist is very sure that it's not a polyp, if it's a uniform thickness, I will do an endometrial biopsy. So this is how I usually do it. There are no definite cutoffs. Generally, the investigative methods that are used are biopsies. Endometrial biopsy with PIPL is the simplest thing that you can do in the OPD with the least pain and exceptionally good concordance with DNC. Some people also can do an office hysteroscopy if you do have access to it. But generally, if a bleeding is persistent and you are not getting anything significant or you're getting inadequate biopsy, I would definitely prefer to post the patient for a hysteroscopy. Okay. And what are the imaging methods that we use? MRI of the pelvis is definitely the standard investigation when you in the context of an endometrial cancer or an atypia, because this is more, it has an 85 to 90% concordance with the final histopath to decide on, whether the myometrial invasion is less than half, more than half, so that helps us in deciding, planning the extent of lymph node dissection. If an MRI pelvis is not available, you can do an expert transvaginal scan also. And in some patients, we need to do a whole body CT scan, either for the PET or a contrast CT. And those are ladies with a type 2 histology, obvious extrauterine disease and sarcomas. The rest of them, it is an MRI of the abdomen and pelvis with contrast. Okay. And this is the possibility of familial cancers. Of course, 5 to 15 are familial. The most common ones that we see are Lynch and Cowden. And these are some of the suggestive factors that could always raise a suspicion of familial cancers. One, of course, is a family history. The second one is a young age, especially when she does not have other risk factors. She has children. She's not obese, well-fertile lady. Lower uterine segment tumors, especially the MRI. If you see a lower uterine segment tumors, highly suspicious of Lynch. You are doing a molecular typing and MMR deficient, highly suspicious of Lynch, undifferentiated and dedifferentiated carcinomas. And there are some pathological patterns also, which would give us an idea of possibility of hereditary cancers. Now coming to the management, I have again split it into hyperplasias and cancers. So endometrial hyperplasia without atypia, as I've told, is not really considered as a pre-invasive lesion. The risk is less than 5%. Most of it just regress spontaneously. Hysterectomy is definitely not a must unless there is something else. Observation is fair. If you're treating, of course, progesterones, hysterectomy is not a must. LNG, IUD or Mirena is the best option always for all hormonal treatments. If you're going to treat atypias and serous carcinomas, definitely surgery is the standard treatment. Hysterectomy with BSO for postmenopausal women. Premenopausal women, salpingectomy is opportunistically to be done. Ovaries can be retained. This does not hold good for serous carcinoma, intraepithelial. Serous intraepithelial, of course, you're going to go for a full staging, as I've already mentioned, because though they are pre-invasive, they still can go into metastatic disease. Fertility can be two types, medical and ovarian preservation with hysterectomy. So there are two types of fertility sparing. One is just a pure medical treatment, completely sparing the uterus and the ovaries. The second option is removing the uterus, retaining the ovaries, right? For serous intraepithelial lesion, no option of fertility sparing. The option for fertility sparing, either medical or surgical, comes only in type 1 endometrioid cancers. Medical management is an option if it's a grade 1, no myometrial invasion. Ovarian preservation with hysterectomy can be offered if it's a grade 1, less than half myometrial invasion. Okay. And the medical options that we give, ideally always Mirena. You can add progestins. Hysteroscopic resection with Mirena is also an option. And the other drugs that we tend to add if the patient is not, regressing on Mirena are GnRH analogs and metformin. So these are the ways I'm sure all of you are aware more than me perhaps. Coming to the surgical management of carcinoma endometrium, as Madam had already asked and I had clarified that point, it's always very important for us in terms of malignancies that we always will have a presumptive risk stratification and staging based on the biopsy and the MRI and an imaging. Okay, so you have to risk stratify. So there are two sets of risk stratification in CA endometrium. I'll just try and simplify that. So there are two levels where we are going to risk stratify. One is pre-operative. It is just stratified into low and high risk. Okay, very simple. And then there's a post-operative, which is, a more prolong a bigger complicated risk stratification, which I have a slide about it later on. Okay, that is to decide on adjuvant. Preoperative risk stratification is to decide on the extent of surgical staging. So in low risk, these are the criteria that we use for low risk. So type 1 endometrioid, grade 1 or grade 2. IHC wise, it is not P53 and it is a less than half myometrial invasion. The definitive surgical procedure is a hysterectomy with a BSO. Lymph node dissection can be avoided here. In high risk, that is, doesn't meet all of these criteria. Any of these criteria are not met, which is either type 2 or a P53 mutated or more than half, or there is extrauterine disease. You're going to do a full staging. And especially in serous cancers and carcinosarcomas, you're also going to do an omentectomy because they are extensively associated with peritoneal metastasis. Now, so though this thing has led to many of these uterine carcinomas being operated in by gynecologists, and then the post-op histopath turns out to be more than half, and then the surgery is incomplete. The doctors also unsure what to tell the surgeon to the patient. We are also confused because now she has the option of either going directly for radiation and not receiving chemo. So a lot of confusions come in treatment planning there. So because of that, so you have to remember that up to 20% of type 1 grade 1s can get upgraded and upstaged in the final histopath. So that is the reason why we prefer that these be operated in onco setups, because of oncosurgeons, even in the lowest risk criteria, so even if they are in the low risk, we will always do a pelvic lymph node dissection. We will only skip the para-aortic, but we'll almost always do a pelvic lymph node dissection to cover up for this possibility of an upgrading. Okay, so this is why we prefer that cancers are done in onco. Yeah.
Shruti, how do we do frozen section for endometrial cancer?
So frozen section is really not recommended. So because at high discordancy, especially when you're doing an endometrial hyperplasia, atypical hyperplasias, so the frozen section, of course, the pathologist will do if you ask for it, but they have a very high chance of missing carcinomas as well as the extent of myometrial invasion. It is very difficult for them to give a true myometrial invasion or to say that it's only atypia and not cancer. So to tell that it's only atypia and not cancer is more difficult than to tell the extent of myometrial invasion. So that is why we don't like the idea of frozen sections, unless in sometimes what happens is we are seeing a patient with postmenopausal bleeding, the MRI and ultrasound are suggestive of carcinoma, but the completely stenosed os, or the lady is unwilling for a dilatation. We are posting her directly for surgery or a vaginal stenosis. So those cases are the only cases we would do a frozen. Everything else is preoperatively decided, risk stratified. So that is the ideal setting.
For the entire uterus, you will send for frozen.
The entire uterus, yes. So if we are sending for frozen, so people do two things. Some people do is that before the procedure, they'll take a nice DNC because the patient is under anesthesia. So they'll take a nice DNC, send the curatings to see if it is a carcinoma or an atypia, because sometimes you would have got atypia, so you want to see if it's a carcinoma or an atypia. The other way of doing it is sending the whole specimen after the hysterectomy, waiting for the frozen report. So both ways we do.
One more doubt, DDC, CC, what is all those things?
So those are undifferentiated carcinoma, dedifferentiated carcinomas, clear cell carcinomas. These are all type 2.
Okay.
But we generally would do an omentectomy in any of the type 2. But what is a must is in serous and carcinosarcoma.
Thank you.
Yeah. So I didn't want too much crowding of my slides. So I have this major obsession with short forms. So when I finished my MCH, I had to give a note of my short forms there as well. So that is an issue I have. So what are the recent advances in surgical options? Of course, minimally invasive surgery, either lap or robo, is the standard in preoperatively predicted early stage C endometrium. So unless you have an extrauterine disease, where you do a laparotomy, everything else. So whatever is restricted to the uterus, the majority of the endometrioms that we see are to be, the standard is MIS now, the standard is not open anymore. Okay, and avoiding morcellation is a must. So sometimes you might get a patient who is infertile, who has never had children, or who's old and her vagina is stenosed. The uterus might be 8 weeks, so you might not be able to take that uterus down. We would never suggest that you struggle and take it down, because that is invariably going to tear the uterus or cause a spillage through the tubes into the peritoneum. So if you have any difficulty removing that uterus out, just put in a small incision and take it out. So that incision is definitely going to be smaller than a phalansteal incision. So you'll always be able to take it out through a smaller 3 centimeter or 4 centimeter incision once a hysterectomy is done. You never struggle with that because that causes tumor spread in the peritoneum. Then sentinel lymph node biopsy is another in thing, which is slowly completely replacing lymphadenectomy. And now the trend is to use ICG, indocyanine green based sentinel lymph node biopsies, which can be done through robotic or even laparoscopic cameras like Stryker, which have the inbuilt near infrared inflorescence. Okay. So sentinel lymph node biopsy is strongly suggested in all low risk endometriums on your preoperative risk stratification. Even in high risk endometriums, also sentinel lymph node biopsy can be accepted, but the preferred is always a lymph node dissection in your higher risk endometriums. So as I've already told, madam, so initially I've told, so there is a preoperative risk stratification, which is just low risk and high risk to decide on lymph node dissection or not. And that is based on endometrial biopsy and MRI. Now we have a post-operative risk stratification. So imagine that the patient has undergone a full staging according to her risk category. And then now we have to post-operatively decide whether we want to give adjuvant or not. And that is going to be on your final histopathology. So this now, earlier it was only based on histopathology. This was the only column that was available earlier. Now it also includes the molecular typing. Okay. So anything which is either MMR deficient or NSMP, which is no specific molecular pattern, is treated purely based on the histopathological risk criteria. All pole mutated go to low risk. All P53 abnormal end up going to high risk, except for this one stage. So this is the basic thing. So pole down stages it, P53 up stages it. Okay. And of course, there are so many criteria which I think would be an excess for residents. So basically, stage 1A, low grade, grade 1, grade 2 with no LVSI, observe. All the other stages, there are options for chemotherapy or brachytherapy or radiotherapy in different forms. So the intermediate risk goes for vaginal brachytherapy if it's more than 60 years, if she's more than 60 years. The high intermediate risks goes for vaginal plus external beam radiation. And the high risk patients go for chemotherapy with or without radiation. So here chemotherapy is the most important thing. Metastatic disease, of course, treatment is always palliative. So it can be chemotherapy, immunotherapy, targeted therapies. That is the other thing in adjuvant. One advance is that molecular typing has also come into the adjuvant risk categorization. Second thing is the incorporation of immunotherapies and targeted therapies. So you have targeted therapy options like bevacizumab for advanced disease. You have immunotherapy options such as dostarlimab, which can be taken in the first line along with chemotherapy in advanced disease. For recurrent disease also, you have the incorporation of pembrolizumab and lenvatinib. So all these are options that we have. Incorporation of immunotherapy in advanced and recurrent diseases. So these are all the adjuvant advances. Okay. So that is about carcinoma, endometrium, and atypia. I hope it was not too confusing. I know that might be a lot, but I've tried to simplify it as much as possible. And just 2 slides on one slide on uterine sarcoma. Again, I've tried to simplify it. There is no distinct lower risk and high risk. This is something that I have put for simplification purpose. There's absolutely no low risk in sarcomas, but relatively low risk would be a low grade endometrial stromal sarcoma, adenosarcoma. Higher risk are high grade endometrial stromal sarcomas, undifferentiated sarcomas, adenosarcoma with overgrowth, and leiomyosarcoma. So these are all histopathological patterns. Lower risks generally can be hormone sensitive. So removing the ovaries is also a must along with the hysterectomy. High risks generally are not hormone sensitive, so you can retain the ovaries. In any of the sarcomas, there is no definitive role of lymph node staging, and there is no definitive role of adjuvants. But generally, in higher risk ones, that is all these leiomyosarcoma and undifferentiated, we prefer to give chemotherapy in most of the stages except stage 1. In the lower risk ones, the hormone sensitive ones, hormonal therapy may always be an option. So the take home points, histotyping, grading, and molecular typing are a must now in carcinoma endometrium. And this preoperative risk stratification is a must using the histotyping, grading, and molecular typing along with imaging. So this is how you do the preoperative risk stratification. And this is for deciding the extent of your surgery. And we always prefer that oncological center be preferred even in atypias because of that risk of conversion to malignancy and the upgrading. Okay. And uterine, and for post-operative risk stratification is based on, again, the histology, grading, and all that in the final histopathology specimen. And that also uses molecular typing. Surgery, gold standard is minimally invasive. Sentinel lymph node biopsy is also slowly coming into the gold standard. Fertility sparing options can be ovarian preservation, or it can be medical treatment. So I have to already mention what the criteria are for that. And these two are only in type 1 tumors. They are not an option in type 2 tumors. All sarcoma, surgery is the primary treatment, and the best treatment, adjuvant treatment reports are unclear. So I hope that is clear. But if there are any doubts, yes, please ask. Hello?
Thank you, Shruti. Such a wonderful lecture, I should say. We have covered almost everything.
Yes.
And it is actually, I wish I was a PG at that time. Now that the PGs are really fortunate to listen to good speakers. How nicely Lakshmi spoke on recent advances in fibroid and now the endometrial carcinoma, the molecular classification. You just take us through like a cakewalk. It's really easy and good. Yeah, I hope that definitely it will be uploaded in the YouTube. That is the other thing. But anyway, listening to you and taking questions on and off is really good. Thank you, Shruti. Supriya, and any comments on ma'am?
Madam, is there any tumor marker like a CA125 who screen for the CA ovary?
No, ma'am. So there is no tumor marker for endometrium, but when we see the type 2 ones which have peritoneal spread, so as I said, serous carcinomas and carcinosarcomas behave almost like ovarian carcinomas. So for those, we do a CA125 that is not really used for risk prediction. They are just used for treatment surveillance. We use it only for treatment surveillance. It is not a must to do it. Many times I don't do it also.
Okay, thank you.
So in endometrial CA, more than CT, MRI is preferable, is it?
Yes, yes, madam. MRI, because the basic difference between CT and MRI is the soft tissue delineation. CT will just show a uterus. That's all. It will not show the details within the uterus. So MRI is what will show which is the endometrium, which is the myometrium, which is the serosa, which is fluid, which is blood. All that will be clearly seen in the MRI.
With
So, but
contrast.
at the same, yes, with contrast. So contrast in that is gadolinium contrast is what is used in an MRI, and preferably abdomen and pelvis, because we want to see the paralytic nodes as well. But suppose we have a patient comes with a supraclavicular node. We already know that she has supraclavicular node. So there I don't want to see whether the MRI has myometrial invasion or not. If the biopsies already come, say, as serous carcinoma, I just need a PET CT for seeing where all the tumor is, so that we have this for surveillance of the tumor. So when we give a chemotherapy, we want to see which all the lung mets have they reduced, have the brain mets reduced, are there brain mets, does she need radiation? So for that purpose, I would prefer a PET CT or a CT. But generally, in an early stage endometrium, the preferred modality of imaging is MRI, which will help in preoperative risk stratification. So these are some of the terms that I want PGs to remember, that they have to use that word called preoperative risk stratification. Because probably for MS, this might not be particularly important, but having done DNB, I know that when we go for DNB exams, you have a lot of oncological cases you get for your exam. And some of these examiners who come are actually people from regional cancer centers. So it's very important that you use these terms, such as preoperative risk stratification with endometrial biopsy and MRI or imaging.
What about fertility sparing? That is the one thing. Suppose if they want to conceive, nullipara with the early stage, or
I mentioned, madam. So fertility sparing options, we are thinking mainly, of course, the best fertility sparing option is completely retaining the uterus and the ovary. That is possible only in type 1, grade 1, and no myometrial invasion on MRI. So if you have, more than half, less than half myometrial invasion, that is not the standard for uterus preservation. But sometimes patients insist. We counsel them that this is not the standard treatment. We write that in recorded with the patient's consent, and we do give Mirena. But those are not standard options. Standard options only if there's no myometrial invasion, grade 1 endometrioid, patient less than 40 years with good ovarian reserve, compliant, no family history, no Lynch syndrome. Your molecular staging also is not P53 abnormal, not MMR deficient. So a lot of criteria if the uterus has to be preserved. But if the patient is okay with removing the uterus and just having the ovaries, it is a slightly more wider criteria. Any premenopausal woman with less than half myometrial invasion is sufficient. You can retain the ovary. You will get a broader number of cases for that.
Only IVF, no?
So then they would have to go for IVF. Yes, we tell them they have to go for IVF. They don't have other options.
No, if the type 1 less than 50%, they can go for normal pregnancy, not possible.
So if we are treating the patient with Mirena, and we will repeat the endometrial biopsies every 3 months with the Mirena inside, and if 2 endometrial biopsies turn negative, we will send the patient to an infertility specialist immediately. IVF is preferred because of the ease because it will be faster and a better success. But sometimes we have seen patients who just conceive with ovulation induction also in one cycle, and they do perfectly well. And these patients, the other thing that I have not covered in my talk is what happens after the patient has completed the family. So patients might have one child, they will want another child. We do not tell, okay, no way, you have to remove your uterus. We do not tell them that. We prefer that they put the Mirena back in, give them a period of time, and then whenever they decide to go for pregnancy, they have to again go to an infertility specialist. In between, once a year or once in 6 months, they have to have endometrial biopsies. Even if they have completed 2 children, there is no definitive indication. They have completed their family. There is no definitive indication to go back to hysterectomy unless an atypia or a carcinoma recurs. So they can still have their Mirena and be on an annual endometrial biopsy as long as there is no atypia or carcinoma recurring.
Great. Thank
I
you.
don't know. Might be a little bit too extensive. I'm not sure.
Very nice, and so many, almost 50 people are staying till 9 o'clock. That is very good, interesting, quite interesting, and very well take home points. Yeah, I think anything I'll be asking you over the WhatsApp, and also tomorrow it will be uploaded in the YouTube. They'll have a lot of doubts. Endometrial carcinoma is a tough thing to crack. Unlike ovarian carcinoma, where you go.
We find ovarian carcinomas worse.
Yeah.
Right. Okay, madam.
Madhu.
Thank you. Thank you so much.
Thank you so much, madam. That was a wonderful second session too. Thank you very much for your thoughts there. And thanks each and every one of the delegates who had stayed until the end of the webinar. Of course, made so very interesting by the 2 speakers. And thank you one and all to all the faculty, the 2 great speakers and the chairpersons who have made the webinar so very interesting today. And thank you all once again. Thanks, Tahiti, for giving us this support and the online webinar support. Thank you very much.
Thank you.
Vijaya ma'am, would you like to conclude?
Yeah, thank you so much, all of you, for staying back. And it was a really wonderful session. And I wish I could call Shruti again for all the gynec cancer, one by one, you and Rajatarangini. It's a very good informative session for the people. They can sit at home and listen to you. That is, instead of attending the conferences, this webinar is in a way is a positive exposure to a wide knowledge. Thank you, Shruti, and thank you, Lakshmi. I think she left. And thank you all the chairpersons, Supriya, Seema, and Arushi, everyone. Thank you. And please vote for me and my last
Yes,
request.
definitely.
Thank you. Tell your friends also. Thank you so much. Yeah.
Thank you.
Thank you, Madhu. And thank you, Sagati. Yeah, good night all. Prasanna Kumari ma'am was there. Yes, Shruti.